My topic is sequelae of septic arthritis of the hip and the practical classification. Now, just to introduce this talk, sequelae occur because of delays in diagnosis. And this is, I think, the most important point I want to make, that diagnosis of septic arthritis has to be done early to prevent sequelae. Here's an example of a patient who had septic arthritis of the hip. The diagnosis was not picked up. See the right hip, the increase in joint space, and eventually avascular necrosis of the femoral head and loss of the femoral head. So the mechanism by which sequelae work, of course, avascular necrosis, loss of the blood supply to the capital femoral epiphysis, then growth arrest, again, because of infection and the sequelae of infection. Femoral neck osteomyelitis, that's a local involvement of the femoral neck, giving rise to angulation and pathological fracture. It can give rise to pseudarthrosis, bone loss, which is partial or complete. And then there could be, because of effusion in the joint, a joint dislocation, so dislocated hip or a subluxated hip. And this pathomechanism actually forms the basis of my classification for septic arthritis sequelae. Unaware of any other classification way back in 1987, actually, when I was working on this, I collected about 75 cases and we studied them to see what sort of sequelae can occur in septic arthritis of the hip. And two broad areas, of classification. One is where the femoral head is absent. That is my type 1 and type 2, and I'll explain that in a moment. Then you have a situation where the femoral head is present, which is the type 3A and 3B, 4 and 5. So if you look at the situation where the femoral head is absent, you can have stability by means of a metaphyseal remnant within the acetabulum, and that is the type 1. So it's a stable variety, but associated with a lot of deformity. I'll again explain the natural history of all of these groups. The type 2 is where there is no connection between the acetabulum and the femur, and that is why it's a totally unstable excision arthroplasty type, which is the type 2. Now, where the femoral head is present, you can have a situation of dislocation or subluxation, like you have in DDH, for example, or the type 4, the group 4, which is avascular necrosis and a Perthes-like effect. So when you have a situation of avascular necrosis, you can have a growth arrest. It can be selective or total, giving rise to coxa vara or coxa valga. When you have a total growth arrest, you have a coxa breva and trochanteric overgrowth. So all these sort of problems can be there. And our understanding of femoroacetabular impingement has gone better over the years, and we realize that an aspherical femoral head or a projection from the femoral head can actually be the harbinger of pain and early osteoarthritis. The type 5 is a special group where the femoral neck is affected and you have a pseudarthrosis because of loss of bone there. Now, each of these groups have their own natural history. To give you an example, the group 1, where you have a stable hip because of presence of a remnant of the metaphysis within the acetabulum. This particular group is very prone to deformities. So these children present with a huge deformity, maybe 30, 40 degrees of fixed flexion deformity of the hip. They also have stiffness. They may have a limited range of motion. The group 2 has an excellent range of motion, but instability and lurch. 3 and 4, 3 will behave like a group 2, depending on actually the situation. If it is dislocated, the movement will be very good. 4 will have limitation of movement because of stiffness. It will have deformity. So whenever you have a situation where you have something within the acetabulum which is not perfectly round, you have stiffness, deformity, and eventually pain. So that's 4 and group 1. And then group 5 is pseudarthrosis of the femoral neck, which is a very special group in terms of management, and I'll focus on that a little later. So when we look at this classification or other classifications, and when we are faced with the case which has a sequelae of a septic arthritis of the hip, the question we ask ourselves is, what is the clinical problem? What does this patient want? What is his problem? So it may be instability, as for example in group 2. It may be deformity in group 1 and group 4. It could be stiffness, again, group 1 and group 4, and shortening wherever there is loss of head or there's a growth arrest or avascular necrosis, you can get shortening. Shortening is common to all the groups, and all these problems need a solution. So let's look at this very briefly. I know that we're going to be discussing cases, so I've not really kept case examples, but just the theory behind the management. So clinical problem when you have instability and lurch. Well, this is typically the group 2, the excision arthroplasty type of group, and you have instability and a lurch, but an excellent range of motion in most of these cases. And this is the example here, loss of capital femoral epiphysis and neck, an unstable group. You could leave the patient alone. If the lurch is not much, you could leave the patient alone if his range of motion is good. Or you can do one of the trochanteric arthroplasties. Different trochanteric arthroplasties have been described, and these can be done. Or one can do a pelvic support osteotomy of the Shyam's or the Elizaro variety. Arthrodesis is not commonly practiced, but has been listed as one of the options in the older literature. Now, when you have dislocation and subluxation, again, an unstable situation, this is group 3A, dislocation, where the capital femoral epiphysis is present, and this is unstable. And then this is subluxation, again, a situation of instability, may be apparent, may not be apparent, but it is a radiologically unstable situation. The intervention follows the line of DDH. So if you have a dislocation, you may need to do a closed reduction with or without an adductor tenotomy, or an open reduction depending on when the patient presents to you, may need a femoral procedure and an acetabular procedure. If you have subluxation, again, you may need a femoral or an acetabular procedure. Now, the problem of deformity and stiffness, typically that of the avascular group, and of course, where you have a metaphyseal remnant in the acetabulum. So this is group 4. Now there is a very large group actually with avascular necrosis, growth arrest, articular incongruity, coxa magna, coxa breva, coxa vara, trochanteric overgrowth, femoroacetabular involvement, but this is stable, a stable joint, but heading for an early osteoarthritis or heading for certain deformities. So here the clinical problem is deformity, stiffness, and pain, maybe with restricted range of motion. And what could be the solutions? Well, there could be a number of solutions in this situation. A plain adductor release can work very well to have that femoral head well inside the joint, or osteochondroplasty is very well known, elongation of the femoral neck where you have a coxa breva, distalizing the greater trochanter where you have a trochanteric so-called overgrowth. Deformity correction, example coxa vara or coxa valga can be corrected. Head reduction for a coxa magna or irregularis. Where you have stiffness, one can do arthrodiatesis. There is an option of a pelvic support osteotomy or an arthrodesis also in these cases. We have so many options, we need to use them wisely. The other treatment options here is maybe an arthroscopic osteochondroplasty, neck lengthening and trochanteric advancement, intertrochanteric osteotomies, femoral head reduction osteotomy on the femoral side, and increase the coverage by means of acetabuloplasties or reconstruction or salvage procedures to improve the coverage. Now, type 5, I'll very briefly focus on this. This is pseudoarthrosis of the femoral neck. This could be stable, it could be unstable. The variety we generally see in practice are actually latent instability, which is present, and one finds that you follow up these cases over a period of time, the neck shaft angle actually goes on reducing, So you may start with a neck shaft angle of 100 with this sort of a picture, and eventually this may go down to 60 degrees. If you have a long-term follow-up, this is what you will probably find. How do you manage this pseudoarthrosis? You can immobilize them in spica in the early phases. One could do a valgus osteotomy and they eventually heal. Or you could fix the pseudoarthrosis, bone graft, and do a valgus osteotomy. Example of a female here, because this is a special group, I'm just giving you one example. Sepsis at 1 month, detected at 1 month of age in 2004. On the right upper hand, you have the situation at 3 years. just watchful expectancy, and this pseudoarthrosis eventually heals. And in my practice, I've seen all of them heal, but the neck shaft angle actually drops, as they go on healing. Maybe because of the stresses of weight bearing, they have a drop in the neck shaft angle. And this requires a correction, a valgus osteotomy. She has excellent movements, excellent function post-operatively. And this is further follow-up after 3 years, I think. The head is becoming more and more spherical. In the lateral view, it's fairly spherical. 4 years, and this is about, this is the function at that time, able to squat, able to sit cross-legged. The only problem she's left with is a shortening, which will eventually require an elongation. So this is in 2019 when she's 15. Fairly spherical head, good function, but the problem of shortening remains. So to summarize, when is surgery indicated in a situation of septic sequelae? Where there are symptoms, where there is a limp, where there is an increasing femoral deformity, for example, the coxa-vara, or a femoral deformity which is present, which is increasing, neck shaft angle is diminishing. So you have a reduced neck shaft or a head shaft angle, which means the coxa-vara is progressive, short femoral neck, overriding greater trochanter, local problems in the neck like a pseudoarthrosis, an acetabular dysplasia, limb length discrepancy, premature physeal closure, dislocation, subluxation, for example. All of these cases will require management. And once you have defined the indication for surgery, we need to intervene when the bone development is sufficient for secure internal or external fixation. So when to intervene, I think, is another question, and we can discuss this when we discuss cases. So again, what sort of reconstruction? Group 1, they eventually become painful and we need to do surgery for the pain. Group 2, we need to stabilize to improve their gait in whatever way, whether by a trochanteric arthroplasty or a pelvic support osteotomy of some type. Dislocated hips, we relocate them unless the situation does not demand, the symptomatology or the physical findings don't demand it. Largely, we would like to relocate those hips if the femoral head is good, viable, strong, round, and of a fairly good size. Subluxated cases, we want to restore the congruity. Group 4, avascular necrosis, the Perthes type of septic arthritis, surgery to improve mechanics and joint function. And then group 5, we stabilize to improve the gait. So the major clinical problems and the solutions which I have put up: instability, observe, reconstruct, or reduce the trochanter inside the acetabulum; deformity, observation, correction of deformity, and sometimes an epiphysiodesis is required; stiffness, soft tissue releases, arthrolysis, arthrodiatesis, or an arthrodesis; and for shortening, we need to do a length restoration. So thank you very much for your attention, and I would welcome any questions.